Alrighty, hello everyone. I'd like to welcome you to today's webinar, Brain Injuries in EDS and HSD, Perspectives of a Neuro-Ophthalmologist with Dr. Eric Singman. My name is Sarah Jo Ritchie. I am the volunteer coordinator at the Ehlers-Danlos Society, and I am your moderator today. This webinar is part of our ongoing series, Living with EDS and HSD. This is how today's webinar is going to work. Webinar attendees will be muted at all times during the webinar. However, you are able to type any questions you may have throughout the presentation into the question box at any time. Dr. Singman will not be able to see or respond to any of these questions until the question portion of the presentation. Please do not send your questions more than once. It will not increase your chances of having your question. It will only make it harder to sift through the questions and to make sure we are able to get to as many of them as possible. Dr. Singman is an assistant professor of ophthalmology, division chief of Wilmer Eye Institute's Patient Access Center for the Eye, and founder and provider of the Wilmer Clinic for Vision Disorders After Brain Injury. He received his MD and PhD at the State University of New York Downstate School of Medicine. He completed his ophthalmology residency at State University of New York Downstate and his neuro-ophthalmology fellowship training at the Kingsbrook Jewish Hospital. Dr. Singman is board certified by the American Board of Ophthalmology and has subspecialty training in neuro-ophthalmology. His clinical expertise includes diagnosis of visual dysfunction after brain injury. Because of his particular interest in effects of the brain injury on vision, he has seen many patients with EDS because they appear to be more susceptible to trauma and less able to recover as quickly or completely as normal. Thank you so much for being with us today, Dr. Singman.
Thank you very much for having me, and it's a privilege to speak to all of you. It's my privilege, absolutely. So before I begin, just a little bit here. Some people ask, well, why did I get into EDS, how I get onto it? And they always ask, so I figured I might as well answer up front. I fell into it the way someone might fall into a really deep hole. A number of years ago, a patient with Chiari malformation came to me, and we tried to help her out. She had some things going on, very, very pleasant person. And it turned out she had EDS. So she told her friends who had EDS, and they told their friends who had EDS, and they told Claire Francomano, and they told Fraser Henderson, and Miles, and all the other people in the field who do this stuff, and they just started sending patients. And it was very flattering, but I realized I needed to learn a lot about EDS, and I did, mostly for my patients. And when I learned about EDS more and more, I was shocked and dismayed. Because I saw certain patterns. One, I saw that EDS patients weren't respected. I saw that they were treated poorly. I saw that the worst thing you could say to an EDS patient was, "You look so good," and it was entirely frustrating to me because I saw a lot of that with my brain injury patients as well. Well, P.S. I started getting patients with EDS who had symptoms consistent with some of the visual motor problems I see after brain injury, and we'll be discussing those today. And I started also seeing some patients with brain injury who had complaints I often see with my EDS patients. Like a brain injury patient might say, "Oh, by the way, I have POTS," or "By the way, I have gastroparesis," or "By the way, I have slow emptying of my stomach," or "By the way, I get dizzy when I stand up." It got to the point where I started looking for EDS in my TBI patients who didn't have a history of EDS. We have 50 patients with putative EDS. Getting people into a geneticist is like getting a camel through the eye of a needle. And so we managed to get now 10 of those 50 patients through, and every one of them to a geneticist had confirmed hypermobile EDS. So we actually wrote a paper after the first 7 got in about the patients with EDS and traumatic brain injury, and findings that were kind of concerning to us about that, things that really were problematic. Remember that many of these patients who have brain injury often got that injury from, let's say, a car accident, and so there's a medical legal component to their condition. And so when their lawyer or the opposing attorney says, well, why are they so sick? It was just not a big injury. you say, well, wait a second, they have EDS, they're more fragile. Or their lawyer says, can you explain to me possible future injuries? They'll say, well, now that they have EDS with trauma, unfortunately, it's not a pretty place as it was going to be if they were just a regular Joe or Jane. And so what I'd like to talk to you about today is my perspective of EDS. And that's why I'm continuing to partner with the Ehlers-Danlos Society. We're working on a second paper right now. That's from our first paper of the big survey that we did of EDS patients of eye surgery. We're now actually seeing those patients who've had eye surgery, and if you have EDS and you've had eye surgery, you're welcome to email me at ericsingman@gmail.com, and if you're interested in getting a free eye exam at the Wilmer Eye Institute, we can arrange that. At any rate, so the title of today's little webinar is The Zebra's Guide to Neuro-Ophthalmic Aspects of Concussion and Orthoptic Rehabilitation. I'm going to go to the second slide. Let's see if that slide comes up. It should say no disclosures. Is that what you guys are seeing?
That is correct.
Great, okay. And so I do have no disclosures. Wish I did, but I don't. And let's continue. So first, let's discuss traumatic brain injury. Traumatic brain injury is caused by a whack to the head. Whether it's a bump, a blow, a jolt, penetrating injury, whatever you want to call it, is a traumatic brain injury. Not all hits to the head cause traumatic brain injury. The CDC in 2003, and remember that's now 17 years ago, used to use mild, moderate, and severe. There's a new textbook out called Mild Traumatic Brain Injury. I have a chapter in that on the vision. And mild traumatic brain injury is not so mild, it turns out. And the rating system, mild, moderate, severe, was really not very scientific and should be abandoned. And you take each patient independently. Whether or not someone loses consciousness is not really useful to me in terms of determining the degree of brain injury when I see them. And recognize that it takes less, I'm fairly certain it takes less of a bump, a blow, or a jolt for an EDS patient than it does of a patient who doesn't have EDS. This is the rates of traumatic brain injury visits from 2001 to 2010 in the United States by sex. As you can see, men have more traumatic brain injuries than women, or at least reported. You would think that if men are more boneheaded, they would have fewer, right? But that doesn't work out that way. But men do more boneheaded things, and that's probably why they get more injuries. But still, the number is overall increasing, and it's, we're talking of rates of 300 to 500 per 100,000 in 2001, going up to 600 to 800 per 100,000. It's at this point, it's over 1,000 per 100,000. So we're talking about 1%, which is a gigantic number and a growing problem. When someone gets a hit in the head, they often go to the emergency room and they get a CAT scan or an MRI or something like that. And they're told, thank goodness, it looks great, go home. Well, maybe it's not so easy. First, as this slide shows, there's a primary impact. You see, the brain floats in the skull. So when someone hits their head, the head moves back very quickly, but the brain doesn't. So the brain impacts with the skull. But then the head has an oscillation. It whips back. It whips forward again. And so the brain gets hit in the back. And the brain rattles around inside the skull. And that damages the brain. The visual motor systems that are involved in making your eyes and your vision work run from the front to the back to the vein and from top to bottom. So it's not hard for a brain injury to hurt something related with the visual system. And the dirty little secret about head injury is you can't hurt your head without hurting your neck. It just doesn't happen. Let's think of the physics for a minute about that. If I make person X's head go in any direction, up, down, left, right, turn, anything you want, it's going to transmit via the neck to the torso, hey, I'm moving, move with me. The torso weighs many more times than the head and says to the messenger, which is the neck, no, I don't have to move with you. But the head says, I'm not in control. I was just hit. I'm moving. And the torso says, get over it. And the torso shoots the messenger, and the messenger is the neck. So when the head goes in a certain direction and transmits that force to the torso, and the torso doesn't play ball and cooperate, it's the neck that gets punished. Getting back to our EDS patients already have bad necks. I think the hallmark of EDS is you have a neck problem. I've yet to meet an EDS patient who says, my neck's great. And so you have a neck that's already in rough shape and you hurt it worse, you're only going to have a problem. When a patient comes to me for a routine examination, I'm going to do a lot of things for that patient to explore the vision. These are some of the same things they do with any eye doctor. The problem is that after this slide, the eye doctors kind of stop and say, gee, I'm not really sure, or I don't really see your problem. The other part of the problem is what the patient can communicate. My EDS patients are among the brightest, sweetest, nicest people I've ever met. But no one's expected to be able to say, I have ICD-9 code H35.51. That's not patient talk. Patients come in saying, I hurt my head and my vision isn't right. I can't read without getting a headache or tired or nausea or dizziness. And so a doctor examines them to look for the basic eye functions to see what's going on. So the first thing they do is they put up an eye chart. This one happens to be, I think it's in Gujarati. And I can't read it, but I thought it was really cool. And they put up an eye chart and say, read the eye chart. And that tests your visual clarity. Great. Most patients with a head injury have pretty decent visual clarity, unless they hurt their eye. Now, there are sometimes they can lose visual clarity. We'll talk about that in a minute. We then test their peripheral vision. When the head is involved in peripheral vision, so is the eye. Maybe the peripheral vision got damaged. Most of the time, it's normal. Again, there'll be some cases where it's not. Then they check their color vision. Except if they're colorblind beforehand, most of the patients have pretty good color vision. Again, we'll talk about the situation. It's not common at all, but it can happen where it's not. Then they check their pupils, and they make sure their pupils react to light. Rarely, they might notice that when they shine a light in one eye, and they see the pupil come down nicely, and then they bring the light quickly over to the other eye, expecting to see that other pupil down, because that's the way the brain works. When one pupil comes down from a bright light, the other pupil comes down too. That's called the consensual response, because they're yoked neurologically. But they go over to that other eye, they shine light on the eye, they see that the pupil is maybe not down, or they see that as they look at the pupil, it gets bigger. They say, hey, that's funny. Then they go back to the first eye, the pupil comes down, as if the brain wasn't seeing as much light. That's called an afferent pupillary defect. That's a really important finding. It's not a subjective finding, it's an objective finding. And it's indicative that one optic nerve is less healthy than the other optic nerve. You can get that with a traumatic brain injury, and not a terribly severe one. That condition is called indirect traumatic optic neuropathy, ITON. I have a lot of research on doing that right now. I have a couple of papers in trying to model what's going on with that. But it's a patient who was hit to the head. The nerve itself wasn't cut by some foreign body. It wasn't cut by some piece of bone fracture that slipped into the nerve canal and hurt it. Just the nerve's not working right. It's not a common condition. We know what happens. We know patients lose vision. We know that the nice pink healthy nerve eventually becomes pale over a couple of months. So we don't know what causes it. MRIs are negative, CAT scans are negative, but visual field tests are abnormal, visual acuity is abnormal, color vision is abnormal. Other tests like a visual evoked potential, which is like an EEG, but measures your information from your eyes, is abnormal. And these patients have varying degrees of reduced vision. Some get better, some don't. Some might have very little vision loss, some can go stone blind, but that can happen. We don't know why, and when we modeled this on a computer, and we just submitted that to an engineering paper, a bioengineering paper, it may very well be, because no one's looked, by the way, that the patients who get indirect traumatic optic neuropathy might have a susceptibility to it, like more pliable bones or weaker bones. No one's ever looked at that cohort of patients to see if that were the case. And so it raises a question whether or not they might be susceptible to have something wrong with their bones. And no one's ever looked to see if they might be EDS patients, preferably or not. That's something that we have to have in the back of our mind. But in the meantime, I'm just putting it out there that usually it's not a common problem, but when someone has it, then you would see defects in a routine exam. Another thing you can see after traumatic brain injury is you can see that patients' eyes are not working together. They might be crossed inward, that's called an esotropia. They might be wall-eyed or an exotropia, or one eye may be higher than the other, that's called a hypertropia. That you can be seen with different kind of cranial nerve palsies, and unfortunately, the cranial nerves that control the eye muscles are very long, they're very delicate, and they're very susceptible to traumatic brain injury, even if you see nothing on CAT scan or MRI. These patients will often complain bitterly of double vision. They often get better, but they often complain bitterly of double vision until they do get better. There are things we can do to help them. We can discuss that at the end of the talk. Another thing we test is stereo acuity. There we give them these, what's called anaglyphic stereo glasses that are polarized lenses in opposite directions. And we have them look at 3D pictures and we see if they can see 3D. It's very common for patients with traumatic brain injury to have reduced stereopsis or 3D vision. We see it all the time. It usually means the eyes don't work as well together. We can fix that, it gets better, but it happens. Another thing we can see with elevated brain pressure, another thing we see with traumatic brain injury is that you can get elevations of brain pressure. And on the eye exam, that can look like a swollen optic nerve. And that's what you're seeing in this picture here of the optic nerve. That central round thing is the optic nerve with the blood vessels coming out of it. Just at the edge of the screen as you look at it on your left, is a darker area that's called the macula. And a swollen optic nerve has to be looked for with someone with brain injury, with someone with headaches. Sadly, you'd be shocked at how many times they don't look for that. I've had a number of patients come in with TBI, months after TBI, with complaining bitterly of headaches, been told they're fine, it's migraine, and we look and their nerves are swollen, and nobody looked. Another finding that's scary to see after head injury, but can happen, usually happens more months after head injury, is you look at the optic nerve and it's pale. It's not pink anymore, it's pale, it's flat, and it means that the nerve has been sick or partly killed. And that's something that can happen with this indirect traumatic optic neuropathy. And this is about what you're going to see with a routine exam. Except for maybe reduced stereo acuity, maybe, a routine exam is not going to pick up some of the subtle problems you see with traumatic brain injury. And that's a problem, because then the doctor is going to say, well, maybe you need reading glasses. In fact, many patients do need reading glasses after traumatic brain injury, and they have reduced accommodation. But we're going to go to that in a second. Let's go to the next slide, show you what I'm talking about. Now let's do a little bit of more specialized testing. What you're looking at now is called the King-Davich test. That's where somebody is given a row of numbers to read. That's the top row. It says 2, 5, 8, 3, 9, then zips their eye across to the next row and keeps reading. And they should be able to read those pretty crisply, pretty clearly. This is a really good test for screening for concussion, let's say in the field, either on the battlefield or the sports playing field. And the patients often get somewhat better, but they don't always get better. And so this could be actually good for screening for even chronic concussion. Another test that's useful for screening is simply eye-hand coordination speed. What happens is the tester, which is who's the person holding the ruler at the top of the picture, is holding the ruler within just above someone's open hand. That's the patient. The tester drops the ruler and the person has to catch the ruler. And they should catch the ruler within a certain number of inches. If they don't, that reduced eye-hand coordination is suggestive of concussion. That's another good screening tool for either chronic or acute concussion. These are prism bars. You probably haven't seen them unless you've been to an eye doctor who does this kind of stuff, but these bars are graded prisms. And that bar on the top, you can see the prisms go from thin towards the top of the bar to fatter and fatter, like a stairway going up, sort of a sideways stairway. And what a prism does is it moves light. It bends light to making it go to one side. What I do is I take the prism bar and I hold it with the fat side away from the patient in front of one eye. So if, let's say I hold it over the right eye and the fat side is off to the right of the patient, and I start with the low weak prisms and I slowly increase the prisms. That makes the image of me jump towards the patient's nose, and the patient starts to cross their eyes. And I measure how well a patient can cross their eyes. And this measures what's called convergence, or voluntary eye crossing. Whenever your eyes have to look at something closer, they converge. They also accommodate, which means they change their natural lenses. That's important because I test accommodation too. But the worst way, in my opinion, of testing accommodation and convergence is that some doctor has their finger and they have you look at their finger as they bring it towards you. And you ask yourself, well, what are they doing that for? You see, it's for my traumatic brain injury patients tell me it's uncomfortable and it gets blurry and doubled. And I say, I'm not sure why they're doing that. Are they testing convergence? They can't be just testing convergence, because if they're moving a finger close to you, they're also testing accommodation or focusing. Accommodation focusing happens when your lens gets thicker as something moves towards you. So they're not testing accommodation without testing convergence, and not testing convergence without accommodation. So they're testing two different variables, which means they're testing nothing. If it's normal, great. If it's not normal, what do you got? I don't have any new information. So I separate convergence testing and accommodation testing. And so I use the prism at a fixed distance from me so accommodation doesn't change, and I test convergence. My patients are frequently of low convergence. Now, low convergence can happen with a TBI. It could also happen with fatigue. And have you ever met an Ehlers-Danlos patient who didn't have some degree of fatigue? I mean, just from not sleeping well because of neck and back pain is fatigue. But there's also brain fog, the ability to concentrate. So those also can lower convergence. Whatever the case is, the convergence is often low. This test here is called the AWEA test. And the patient, when they use it, sees two half circles. Now, I put on special glasses in this case. One glass is a reddish glass, one glass is green. And the half circles, you can't tell from this picture, it's not a great picture, but one's red, one's green. And so one eye sees one half circle, the other eye sees another half circle. So the eyes now are seeing two different things. What I've done is I've broken what's called fusion. And by breaking fusion, I can see now how the eyes react when they're not working together, because they don't even care about each other anymore because they're not seeing the same thing. And so what I do is I show my patients this picture and I say, what do you see? And they might say, well, I see a half circle that's nice and straight and one's tilted over. And then if you flip through this little book of these half circles, I finally get to one where the two half circles are nice and straight. And I ask them, are they straight or not? If they say, yes, they're straight, I say, that's great. If they say, no, they're not straight, then I can turn the pages until they are straight with a circle progressively tilts either in or out. I can turn it upside down to make it turn in. I can leave it upright to turn out. And when they say, oh, that's straight, that's a measurement of how much their eyes are abnormally torted or torsion or turned. That's called a cyclophoria or a cyclotropia. That can happen after traumatic brain injury. And it's a very frustrating situation because prisms, which we normally would use to help an eye when it's too high or low or left or right, don't work with this. In addition, it's very frustrating because if a person with a traumatic brain injury gets what's called a bilateral fourth nerve palsy, their eyes, with a unilateral fourth nerve palsy, one eye will look high, one eye will look straight. With a bilateral, both eyes end up going high, but a patient can pull them down. So the eyes look straight, but the eyes are rotated out with respect to each other. So a person has double vision, not where the two images are, let's say, side by side or above each other or diagonal. The two images are overlapping, but they're twisted. Imagine the frustration of that, and imagine trying to explain that. My first patient with this was a patient as a young man, who was a very sweet young guy, didn't graduate high school, worked parking cars in an auto auction, hit his head, and was bitterly complaining that he was seeing not right. And everyone said, your eyes are fine, until we did this and we found he had a bilateral fourth nerve palsy with 12 degrees of excyclotorsion. And so, again, you have to believe your patients, you have to believe in your patients, and you have to keep looking because they'll tell you when something's not right, it's not right. And so this often gets better, but this is a very subtle way of testing for that, and it's a very useful way of testing for it. Another way of testing for it, again, for those of you who are opticians, ophthalmologists, etc., optometrists, when you look in the eye with the bright lights and you see that the normal rotation of the retina and the retinal vessels is not normal, you know the eye's torted. But that's just something for the. I happen to give this talk also to eye care professionals, so I throw that in for them. Another test I do is this. It's a simple pendulum. But you'd be surprised how many patients tell me they hate this. It gets them nauseous, it gets them sick, they can't stand it, they have to look away. So anyone who's getting sick, I apologize, look away, I'll get off the slide right away. But the reason I do that is because patients with traumatic brain injury often have difficulty with smooth pursuits, and a simple pendulum is a nice way of testing that. Another thing we test, and these are colleagues, Laura Balser and Steve Galetta, they're really brilliant people. In fact, Steve now is the chairman of neurology at NYU, Langone, and Laura went with him when they went there. Another thing we test is something called saccades. The saccade is a rapid eye movement. So the way I test saccades is I say to a patient, okay, I hold out one hand and I say, look, that's my palm. I hold up my palm. Then I point to my nose, say, that's my nose. And I hold out my other hand on the opposite side of me and say, and I just hold up my thumb. So I tell the patient, when I say nose, look at my nose. When I say thumb, look at my thumb. When I say palm, look at my palm. And they do that, keeping their head still, and they rapidly move from one to the other. Those are called saccades. TBI patients tend not to do that so well. They might get dizzy, they might get nauseous, they might get headache, but they also sometimes overshoot or undershoot. They sometimes, because of cognitive disturbances, try to have to remember, wait, what's a palm again? What's a thumb again? It's amazing to watch how difficult it can be for these poor people. Another thing we see is glare. Glare after TBI is a misery. We don't know what causes it. We can't help it very well. I offer all my patients Maryland window tint waivers so they can get darker windows. I write accommodations for school and for work, but glare is a real problem to deal with. Cognitive difficulties are a real problem to deal with. How many of my patients, when they come to me with TBI and I ask them, are you dumber since the TBI? And they say, thank you. Yes, I'm done. They jump up and down with joy that I called them dumber. Most people would do that. But the reality is they want someone to recognize they're not the same person. After a TBI, they feel dumber. They can't multitask the way they used to. Their memory isn't what they used to. They have word finding problems. They can't keep up with conversations. Their sense of humor is not the same. Their likes and dislikes are not the same. They're more irritable because of this. Their relationships change. It's something I ask about, and it's something I try to help patients with. Here's another problem. Remember we talked about the neck. This is a problem I see a lot in my EDS patients with or without trauma, but after trauma, it gets worse. And that we published in our EDS population of the 7 patients that we confirmed EDS. They get occipital neuralgia like crazy. Occipital neuralgia is pain from soft tissue injury to the neck that goes forward across to the eye, and it causes referred pain to the eye sockets. You press certain areas on the back of the head and the neck, and they'll say pain that radiates forward. The sad part is many of these patients only notice the eye pain and go from eye doctor to eye doctor to eye doctor to neurologist to pain to saying my eyes hurt. And people say, look, I'm sorry, I don't find anything. They get MRIs and CAT scans. Your eyes are fine. Look, they're told they have trigeminal neuralgia. They don't. They're told they have migraines. It's not. They have occipital neuralgia with cervicogenic pain referred to the orbits. And when you give them a nerve block back there and the pain washes away, it vindicates them and makes them feel better at the same time. Another problem with brain injury, and for some reason I see it more in my EDS patients, I'm not sure why, is they grind their teeth. They grind their teeth like crazy. That's called bruxism. Bruxism is known to be more common after traumatic brain injury. We're not really sure why. I have some thoughts about it, but they're theories only, so I'm not going to bore you with them. But I can tell you that bruxism is a problem, not just for your teeth. Bruxism can cause TMJ pain. Now, TMJ pain in a regular person is bad enough. TMJ pain in an Ehlers-Danlos patient, I would be shocked if someone I'm talking to today doesn't have some degree of TMJ pain and bruxism. And that just makes it worse. They also get earaches from this too. Another problem, and I haven't seen this more often in EDS patients or not, and I do ask about it, but I'm sure it can happen, is they get dehiscence of the semicircular canal. Now, the semicircular canals are these little bony canals in your inner ear, and they have very delicate bones. And if after a head injury, and not a real severe head injury, causes causes some thinning of one of these canals, then sound waves can get in to the canal, not just by its normal route, but by this new bony window. That's what you're looking at the very top of this picture. You see in the three bony canals, the three round canals, at the top of the superior one, you see a little area with a little red arrow. That's called a window or a dehiscence of the canal. And all of a sudden, these patients describe things that are absolutely crazy. I mean, but they're real. So they'll describe to you when they say, doc, now again, we don't have phones the way we used to have phones, but we used to have telephones that used to ring, okay? And so I had a patient, brilliant man, who had a head injury, and he said, when I call someone on my cell phone and it rings, my eye jiggles. And I'm saying, hello, really? He says, yeah, my eye jiggles. And so it turns out that that's really a thing, because what happens is that the sound waves go into the window and stimulate the vestibular system that controls eye movements, and it makes the eye jiggle. So it's pretty impressive to see that, but it's not common. But when patients tell me that they hate certain sounds or they hate repetitive sounds, that's the first thing we look for. It's called Tullio's phenomenon, by the way. Tullio's phenomenon, T-U-L-L-I-O-S. Another thing that we see with patients with traumatic brain injury, and again, we don't know why, is they get dry eye. Now, Ehlers-Danlos patients get dry eye for a couple of reasons. One, because they have dysautonomias, and dry eye probably associated with that. Two, they're often more nearsighted and they wear contact lenses. That causes dry eye. But plain old traumatic brain injury, for some reason, causes dry eye, and we don't know why. And they also have other problems. We mentioned the depth perception problem, but they also have eye-hand coordination problems that are more subtle. And you see things like they overreaching or underreaching or pouring and missing. In terms of diagnosing these patients, we're getting better at it. We're getting things like diffusion tensor imaging and PET scans and pupillography to show that there are dysautonomias. For example, pupillography, there's growing evidence to show that the pupils don't respond as quickly or with as great an excursion after TBI. but we also are getting more sensitive ways of looking at the brain after TBI to see what's been damaged. The problem with these is that although they're very promising, they're not ready for prime time yet, and so they're not able to be used to make clear diagnoses yet. And so unfortunately, there are people out there who do these kind of tests and charge a mint for them and say, yeah, the tests show this, but they're probably not admissible in medical legal cases, which is a shame. But we need more data to make sure we're looking at the right thing before we say this is a new way of picking up subtle TBI that would otherwise be missed by normal, regular MRI or CAT scan. I tell my patients that the TBI team takes a village, and it really, really does. These are just some of the specialists who I have to work with and I work with frequently. And I take responsibility for my patients so that if I feel they're not seeing one of these specialists and I need them, I try to hook them up with one of those people. Somebody's got a quarterback for these patients. One of the things I find in a center of excellence that makes centers of excellence work, like a cancer center of excellence or a heart disease center of excellence, is they provide the patients with someone called a guide. And that guide can help them navigate this maze. In TBI patients, we need TBI centers of excellence, like the military has the Intrepid Center. We need things like that because TBI patients already have cognitive problems. And so navigating this maze of specialists is twice as hard. In terms of neurothymic rehabilitation, there are some things we can do. When there's frank visual field loss, we can try to make patients more aware of their peripheral vision by using something called peliprisms. That's in the glasses, the little prisms on the glasses you see. There's also been some work trying to expand the visual field by training and practicing with a computer. It's a very expensive program, and it's not been proven that it expands the visual field, but it probably does make someone more aware of the missing field and make them more cognizant to look around. With visual acuity loss, you see somebody holding a handheld reader on top of a can. We have all sorts of magnifying devices that can help with that. But we also have devices, as you see the person wear those funny glasses, we see devices that use virtual reality that can try to fit vision into what's missing to try to help someone see better. In terms of neuro-ophthalmic evaluation or rehabilitation, when someone has frank diplopia, we can put prism in their glasses. Of course, you can occlude. Now, we don't use a pirate patch anymore. That's that center one. But what we can do is we can occlude by just occluding, let's say, a small portion of the vision. Usually we occlude, if you can see my cursor, I'm holding the cursor, we just occlude over the center of the eye so the patient maintains peripheral fusion. Sometimes we have to do surgery to straighten the eyes out. Glare is a tough one. Glare is a tough one. All sorts of glare guarding lenses like FL41 have been talked about. They help some, but glare is a tough one. As far as higher ocular motor dysfunction like convergence insufficiency and deficiency of smooth pursuits and such, that's something that we use frequently. And there are a lot of people who do in-office therapy, and that can be very expensive for patients. It's not covered by insurance. They have to travel to see the professional, and unfortunately that the road trip back and forth already takes a lot of the patient. And the visits can't be brief 5-minute visits. They have to be a half hour, 45 minutes. And that usually is more than patients can often handle. So the in-office therapy is great if your in-office therapist could do a 5-minute visit when you're first starting and he lived next door to you and he didn't charge you or didn't charge you much. They do great work. What happens when those three things stop a patient from going? There's a lot of online and computer orthoptic exercises that do a pretty good job in my experience. And that the nice thing about them is they're very inexpensive. They're one fraction of the cost, really a tenth or less of the cost of in-office therapy. A patient can do them for a minute or 2 minutes or 5 minutes, as little as they want. They can do them in their jammies in their bedroom on their home computer at midnight or in the morning. And we can do it as frequently or as infrequently as we want, because it's one price and it's done once and done. I've had a lot of success with that. I like these programs a lot, and they're easy for my patients, so I use them fairly often. One of my favorite ones is called Visual Edge, VIZUALEDGE. I promise I don't get any money from them. Another is Home Therapy Solutions, HTS. Now, let's jump more about EDS patients. I told you EDS patients fascinated me, and we said, look, the literature out there is frankly missing. Part of it is because people never thought of looking. Part of it was because EDS is hard to diagnose. Part of it is because people don't bother diagnosing it or don't ask, or that, medicine is siloed. I hate to say it, but it's siloed. And so, you ask a lot of ophthalmologists, did you know your patient had Ehlers-Danlos? No. Did you look for it? No. Did you ask about it? No. On your review of systems, what did you ask them? Well, just, how's your eyes doing? Well, on your review of systems, you ask, how's your tummy doing? How's your neck doing? How's your kidneys doing? How's your bladder doing? And most patients get tired of answering, just say, I'm fine, leave me alone anyway, unfortunately, but true. At any rate, so these are 3 patients we put out just in the last couple of years. The top one was the one where we had a survey through the Ehlers-Danlos Society. You guys are awesome. We got 600 responses, and I promised to make a contribution for every response. So we just made a donation of like $2,000 to $3,000 to Ehlers-Danlos Society because of you guys. The next one is, these are the patients. That's the paper we just put out about diagnosing Ehlers-Danlos when we're looking at concussion patients. They didn't know they had it. We didn't know they had it. And the next one is the review article we did with some of the big names in the field about, you see Claire Francomano's name in there, Paola Bolognese and Fraser Henderson there. These are the patients who, just to give, just because we really had to update, especially because the Ehlers-Danlos diagnostic classification system was updated, we felt it was only reasonable to update the neurologic and spinal manifestations of Ehlers-Danlos. They get more headaches, they get CSF leaks, they get elevated brain pressure, they get Chiari malformation, and that's where they come to me, and that's where it's been a big of a problem, because when I know or think a patient has Ehlers-Danlos and they come to me, all of a sudden I have to widen my venue. I can't just say anymore, oh, it's a migraine. The patient tells me, doc, it's a horrible pain in my neck. I have to worry about a carotid dissection now. It's an Ehlers-Danlos patient. You have to worry about that. They come to me and saying, doc, I got this horrible headache. It's worse when I stand up, and everyone says it's just migraines. I have to worry about a CSF leak. Most of the time, these patients have had an MRI, but without contrast, you can't see a CSF leak, because the CSF leak is going to show up only with contrast. So there are so many things you have to widen your differential diagnosis for, and you have to be attuned to, just because they have Ehlers-Danlos. It makes a huge difference how we look at these patients. They get more Chiari malformation. We know that. We don't know why. Maybe because the tissues are softer and the brain just sinks. But Chiari malformation, which is where the cerebellar tonsils slip below the foramen magnum, then your brain starts to drop through the hole in the base of your skull. That particular problem can be subclinical until a head injury, and then it can become clinical. And so all of a sudden, you have to think about that. So this is where the Ehlers-Danlos picture really makes it harder for professionals. But that's not the Ehlers-Danlos patient's problem. That's the professional's problem. Their job, if they have an Ehlers-Danlos patient, is to become more aware of Ehlers-Danlos, to care that much more, to become that much more of an advocate for their patients, and to recognize that because there's so much we don't know about Ehlers-Danlos, we have to be on the patient's side. It's just too easy to say, oh, it's in your mind, oh, it's in your head, oh, you're crazy, oh, you're a complainer. It's too easy to say that. Yeah, it may get the patient out your door, but it's not going to get the patient better. They hurt a lot. You have to be patient with them. I'm happy to take any questions.
Alrighty, thank you so much, Dr. Singman. That was a fantastic webinar, and we really appreciate you joining us today. We have a few questions in, but as a reminder, you can still type questions you may have for Dr. Singman in the question box, and we'll do our best to get them answered. So the first question, let's start simple. Can I do anything to help my TBI recover faster?
Yes and no. I know you hate hearing that, but I'm going to say yes and no. First, I tell all my TBI patients, let's talk about your lifestyle. And I make sure the diet is good. I make sure I want them to have, I call my TBI supplement list. So I like them to take choline. I like to take inositol as supplements. I like to make sure they're getting good vitamins. I like sure they have good nutrition. They drink a lot. I ask about sleep, because if they have bad sleep, they're not going to get better as fast. I ask about bruxism of the grinding teeth. I ask about all the things I talked about, just to get a picture of, to see what might be slowing down their recovery. And we work on those. Then I see if a lot of my TBI patients, with the vision at least, are very bright people, and they've developed workarounds. So for example, instead of scrolling on the computer, which makes them nauseous, they look away and then they look back and they try to find something. Or instead of reading, they use text-to-speech and speech-to-text, which is all perfectly good workarounds, don't get me wrong. But by avoiding the orthoptic, the eye motility rehab, they're just detraining the visual motor system. And that can be a problem. Now, if they're going and having rehab that's too stressful for them, that actually is going to make them go backwards. One of the papers I didn't put up there, because I couldn't put everything up, but I already wrote a paper that migraines probably can lead to convergence insufficiency. And Ehlers-Danlos patients get more migraines. So if they're doing things that make their migraines trigger more often, they might not get the visual motor problem better. It's like 3 steps forward, 2 steps back. So I look at if the TBI symptoms they're talking about are visual motor symptoms, then I look at their rehab schedule and I try to work with them to fit something that fits better into their lifestyle. Now, I gave you that caveat about their necks. When the neck is bad, my efforts go down the toilet. I just cannot get good improvement when a person's neck is miserable. It just doesn't happen. And I'm going to try to explain why that is. Let's say I go to Miss Ritchie and I say, hey, look over there at that beautiful running horse. She'll say, oh, I love horses. I'll look at that running horse. Supposing her neck feels great and she feels healthy, she's going to use her neck and her torso, her large muscle groups, to turn towards the horse. Then she's going to use the fine muscle groups controlled by her vestibular system and ocular motor system to focus on the horse. And she sees a beautiful running horse. Now let's say, God forbid, Miss Ritchie's neck is a misery. It doesn't take long for your brain to say, I don't want to use my neck. I'm going to split my neck. It's involuntary. They don't use their necks. So they try to recruit the small muscle groups, like the eye muscles and the vestibular system, early on. And those muscles, that's not their job. Now we're asking a racehorse to pull a plow. And so it doesn't work. And so it's a misery for these patients. So that's why when I have a patient who's not doing well with the traumatic brain injury recovery, I say, look, let's see how your neck is doing. Now, I have a couple of patients who just are not getting better. And that's why we published that paper. Unfortunately, the trajectory of recovery is slower and less steep in my EDS patients based on my experience now that I'm seeing them. We'll be working on a much larger series of patients as we get them into geneticists. And that we already have a number of TBI patients who are known to have Ehlers-Danlos and they have TBI. So we have a fairly large cadre of patients with Ehlers-Danlos and TBI, maybe 70 or 80 at this point. And I'm seeing them just not do as well. So that's something that may have to be in the cards for EDS patients. It's a bitter pill to swallow, but sometimes we have to do it. And sometimes knowing is better than not knowing, because if maximal medical improvement is going to be suboptimal, at least the patient can try to get some disability or something for it, or work accommodations for it. I'll take the next question.
Alrighty, our next question is, since EDSers are also susceptible to CCI, Chiari, and other comorbid conditions, what is the best way to figure out if vision is blurry or you're having vision issues, if it's due to TBI or something like instability, Chiari, POTS?
Well, I mean, the first thing I would do is I would want to examine the patient and see what their imaging shows. And then I would do the eye exam that I just mentioned. That's the bottom line. And without those, without doing those eye exams, I just, obviously I wouldn't be able to say.
Alrighty, thank you so much. Are there any useful ways to help symptoms like struggling to find words and the like? I would provide more examples, but I can't find the words for them.
Yes, there are. I like my patients to see, I like my patients to go see I ask all my patients to see neuropsychologists to get a full neuropsychological inventory, and then start speech and language and cognitive rehab. No questions about it.
Alrighty, thank you so much. Next question is, I've been in 2 serious car accidents and received total occipital and TMJ nerve blocks every 2 weeks at a minimum. All other treatment has failed. How long can one safely get nerve blocks this often?
As someone who's not a pain management specialist, I probably could not answer that. But if I were getting that often, I would talk to the doctors about nerve ablation.
Alrighty, thank you so much. Next question is, I have a cavernous angioma that bled and caused a hemorrhagic stroke. Have there been studies regarding such lesions and their relationship with EDS? And are there any measures that I as an EDSer should take?
Cavernous hemangiomas happen, whether EDS or not. My instinct suggests to me that they may have a higher risk of bleeding in the patient with EDS, simply because the walls of the vessels are not as healthy and strong. As far as precautions to take, there's a perfect example of somebody who we want to be really, really careful about trauma, about any kind of sports that have sudden bouncing or knocking around. That's a perfect example of somebody who I'd want to exercise by low impact, like swimming, walking, and cycling, kayaking, and canoeing, rather than, let's say, football or baseball and things like that, where there might be impact, soccer like that. But it just stands to reason that that a person with a vascular deformation that could bleed has a higher risk of bleeding with EDS.
Alrighty, thank you so much. Next question is, in regards to prescription glasses, is it best to get 2 pair, one with blue tech and anti-glare and one normal? Or is it okay to wear the blue tech and anti-glare all day?
Okay. It's certainly not harmful to wear the blue tech and anti-glare all day. That's number one. Number two is that I don't know yet. I mean, some of my patients love their blue tech and anti-glare. Others have told me it hasn't made a difference. If a patient likes it, by all means use it. If they don't like it, don't. One of the things I found with my patients, I often give them multiple pair of glasses, but not for that reason. Many of my patients after traumatic brain injury can't stand progressive bifocals, and they often need them. It just makes them nauseous and feel sick. And so I actually prescribe them glasses, one for distance and one for, let's say, computer distance, and sometimes even one for near. Now that sounds prohibitively expensive, and maybe 5 or 10 years ago it was, not anymore. Now that you can buy glasses online, these glasses, I have a patient who bought 3 pair of glasses of the kind I just described online, single vision only. The 3 pair together was under $40. So I buy my glasses online. The cheapest place I could find is one place called iBuy Direct, E-Y-E-B-U-Y Direct, D-I-R-E-C-T. Another is called Zenni, Z-E-N-N-I, Zenni Optical. I was delighted with, I actually, Wilmer Ophthalmology owns optical shops. And so I know I'm really probably, tying a rope around my neck by actually going online and helping patients and talking them through buying glasses online. I even measure their pupillary distance for them so they can buy glasses online. Because if they need multiple pairs, they shouldn't have to pay hundreds of dollars when they can get perfectly glasses for 10. So I often do have patients with multiple pairs of glasses for that reason.
Okay, thank you so much. How should patients best advocate for themselves with their neurologists? Wow. I think I need some new glasses. How should patients advocate for themselves with their neurological doctors, especially if a doctor isn't bringing your hypermobile EDS diagnosis into consideration during treatment?
Well, just get another doctor, duh. I know it's hard to do that. I think a doctor has a responsibility to at least talk to a patient. And if a patient has a concern, if they can speak up, and again, if they have a TBI or they have other problems where they can't find the words, it's halting, it's difficult for them to communicate, to bring an EDS aware advocate for them to a visit and help explain those things to them. But a doctor has a job of also talking to patients. We're not veterinarians, we're physicians. And so patients are expected to communicate with us, and we're expected to communicate with them. Even if it takes a whole visit just for communication, it's part of our job and it's part of the patient's responsibility to make sure that happens. If a doctor refuses to communicate with a patient, that's not a doctor, you get a different one. But if the doctor is willing to communicate, but maybe they're a little uncomfortable because they don't know enough about EDS, that's where you could say, okay, if they have an EDS more aware physician, maybe you could ask the doctor to speak to that physician. I speak to physicians all the time to try to communicate what I know. And, you know, it depends on what that doctor is treating. If that doctor is treating seizures, and that seizure medicine can have an effect on their POTS, that doctor has to be aware of that. If, on the other hand, that doctor is treating some other thing like, you know, Botox for migraines, chances are that's not going to be a huge difference between EDS and non-EDS. So it depends on what the EDS issue is that's not being taken into account. If a patient has Chiari malformation, then it may be that that patient needs to see a Chiari specialist, or like the Chiari, or a team that specializes in Chiari.
That was a fantastic answer for a sticky situation. It's very appreciated. We've got time for maybe 2 more questions. The first of those 2 being, do you have an opinion on Syntronics or color goggle therapy?
I don't have an opinion on it. I do know that some of these therapies have been tried. I see them when I go to meetings, people working on it. I like to look in the published literature to see how the stuff is being used. And if I don't see much in the published literature and I don't see much in the neuro-optometric community that says this helps, I then say I can't necessarily recommend it. If a patient says they love it, it's made a huge difference in their life, then I would say, great, do it.
All right. Thank you so much. And the last question we're going to try and squeeze in today is, I got a concussion in 2014 that eventually led to my diagnosis of EDS and POTS. My most mysterious symptom is facial pain and swelling on only the right side, along with numbness and tingling down my right arm and right-sided headaches. Also have jaw pain on that same side. What are your thoughts on one-sided symptoms?
They don't shock me at all. We see it frequently. We see it frequently. We see it, you know, if somebody has, let's say, occipital neuralgia on one side, we see that. If they have bruxism, we can see it affecting one side more than the other. Doesn't shock me in the least. Hemifacial spasm can happen, and that's only on one side. So one-sided symptoms don't bother me at all. However, I do like to make sure that there's nothing funny going on there. So I often do an MRI and an MRA on a patient like that to make sure there's not some sort of blood vessel that might be sitting near the 7th cranial nerve or doing something funny that could be explaining a structural lesion that could be explaining that one side.
Let's go with one last quick question, because this could affect everybody. How does EDS affect the healing aspect of a concussion, and is there anything we can do to make them heal faster?
The paper we wrote suggests that EDS makes things slower and less progress. That's what I think is going on with EDS. To help it is what I said before, is I would go over the entire patient. I would make sure I'd give them clean up their lifestyle if there's anything I got to clean up, and make sure they have the make sure also, if I can, they have the social support they need, because that's, emotional support is a very big part of healing with this. Make sure that we don't have any impedances to their problem, like severe pain in places that are just stopping things from coming up the works. And then I try to talk about what some of my patients have taught me. I call it my TBI diet, with certain nutrients and vitamins, good nutrition, good hydration, things like that. Sometimes we just have to let time run its course. And sometimes, sadly, and again, I hate to say this, I don't try to bring people down, but sometimes, sadly, the patients just don't do as well.
Alrighty, thank you so much for clarifying that. Unfortunately, we have a couple questions left in our Q&A box. For those of you that didn't get your questions answered, please reach out to our helpline. They will be more than happy to help answer your questions or direct you to the person that can help answer your question the best.
The other thing is that if Ms. Ritchie, if you feel any of those questions are germane to something I can answer, you can forward them to me, and I can answer them and forward them back to you. And if that's possible, then you can get if that's helpful to you at all.
Yeah, I will get some of them down, and we will get some answers, and I will look into finding the best ways to getting everybody their answers, and perhaps we could get them back through email or something. If you are in the chat and you had a question that was not answered, please reach out to me, sarah.ritchie@Ehlers-Danlos.com. So that's SARAH.RITCHIE, and we'll get those questions answered for you. Another option is our website has a lot of resources, information. We've got our helpline that you could call or email, and consider signing up for our newsletter if you haven't already. It's another fantastic source for up-to-date information. Our next webinar will be on Tuesday, March 24th at 1 p.m. We're going to have Shani and Rebecca, our wonderful helpline staff, join us for a special Ask the Helpline webinar, where you can submit your questions to the helpline and they will be answered live. The sign up for that webinar should be up and running on our website. Please take some time to check that out. The information on how to submit a question is in the description of that webinar. Thank you again so much, Dr. Singman. Your presentation was extremely informative and very helpful.
Thank you all. My prayers are with you all, and I'm here for you all.
We appreciate it. Now, technology permitting, this webinar should be available on our YouTube channel within the next week or so. If you found this webinar helpful in any way, please consider hitting that like button once the webinar is available, and that will let you know when we have other ones. Subscribing will also help. So I just want everybody to have a fantastic weekend and enjoy the rest of your day. Thank you so much.